This is Jerry Hesch from the Hesch Institute. This is our website. We have a clinic near Las Vegas, Nevada. We provide consultation, treatment, and seminars and distance learning. We have an interesting case today. Not a case, it's actually an explanation regarding special tests that we perform for sacroiliac joint dysfunction. And some clients are concerned that they might have instability. Some clients are concerned that they may need a fusion. And so by showing you some of the special tests we perform, that will be informative in making wise choices when one gets a workup for possible instability or consideration of a fusion. So if I would have you lie on your back, Holly. Head up here, please. There are several passive motion tests that can be performed through the pelvis, and this is very helpful in specifically isolating where movement is excessively increased or excessively decreased. If Holly were to present with asymmetry of her pelvis, it would be inappropriate for me to give it specific names. Arbitrarily, let's just say that I assumed that she had an anterior ilium because it looked like an anterior ilium. In truth, it could be a phenomenon on the other side of the pelvis, such as a posterior ilium pattern, could be a left upslip pattern, etc. I'm going to demonstrate a spring test, which is also called Hesch springing with awareness because it's a modification of the typical spring test. And what I do is push through the pelvic structure to an end point. So we've taken up the slack through her pelvis. Some of it takes up in the hip, some of it takes up in the lumbar spine, and then we impart an additional force. Now, if she were unstable, this would feel like mush. It would feel unstable. The recoil would be very slow. In her case, I can take up the slack with a normative amount of force, and when I spring it, you can probably see that recoil. She has good integrity, good mobility in that structure. These tests are very similar to the very tests that orthopedic surgeons use to evaluate joint instability at other parts of the body. So I'm going to contrast that test with a test at the knee. This is a classical orthopedic screening test for the anterior cruciate ligament. The knee is flexed approximately 20 degrees, the femur is stabilized, tibia is grabbed, and you draw the tibia. And if the tibia were to shift more than just 2 millimeters, it would be graded on a 3-point scale in terms of hypermobility. She happens to be very solid. I have a son who had a severe motorcycle wreck, and his knee is sloppy in both directions. I wish he were here to demonstrate that. But that gives you a good introduction to the spring tests, and these spring tests are done in supine, and there are several of them. It's important to test the mobility of the entire pelvis. And so this test is testing side mobility of the pelvis. There are some patients who have a pattern in which the pelvis is stuck in side glide to one side. You may not see it, but you can feel it when you perform the passive spring test. And that test will create some pelvic asymmetry, but the cause is a group phenomenon involving both hip joints and involving the pelvis as it moves on the hips, with the hips, and with the lower spine. So when someone has a pelvic side glide dysfunction, it's important to evaluate, treat it, correct it before one considers a true sacroiliac joint problem. So I'm going to also demonstrate screening the pubic joint. The belly button is here, and so if I indent on the belly button and come down the lower abdomen, I will encounter the pubic joint. Okay? And it is a true joint, but it moves very little. So I can place my hand on it, and now I know that the right side is here. Midline is right here. So I'm on the right pubic structure, and I cross over again, and I impart, I take up the slack and then spring the ilium, the pelvis here, to determine if, we're going to ignore that phone, to determine if there is excessive movement in the pubic joint. If we found that, then we would consider that instability in the pubic joint is driving the system. That might be primary, and any sacroiliac pain, any pelvic asymmetry might be secondary to that. And it's important to know that in the presence of pubic instability, that is a much more important problem than sacroiliac joint dysfunction. There's some very good research on that. You can go to the website and you can find some of my writings. So it is important to screen the integrity of the pubic joint, and one can do 8 different spring tests on the pubic structure, multiple directions. Would you kindly lie on your stomach? It is important to also do spring tests when the client is prone, and we do several on the sacrum. We do approximately 8 on the sacrum, actually 9. And we do several on the ilium. Here's an anterior ilium spring test. Here is an inferior ilium spring test. Here is a superior ilium spring test. Here's an anterior one done to the lower ischium. So that gives you some ideas. Another very important screen test is to palpate the ligaments. The long sacroiliac ligament inserts on the PSIS, that bump, and so it's important to palpate across and determine the tone of it. The sacrotuberous is a huge stabilizing ligament, very important one, on the lower pelvis, and it's important to palpate and spring it and compare sides. In the presence of instability, it will feel very lax. A strong ligament, you will be able to indent through the skin, the fat, the muscle, onto the ligament, which will feel like a 3/8 inch nylon rope that's being stretched. And so it should have integrity. Whereas if it was slack, it would feel more like muscle, in which, it would feel very slack. But it is in a very specific location, coming to the medial ischial tuberosity off the sacrum. And it's very easy to find. It's a very distinct feel. There's another ligament, sacrospinous, and that's another important one to test. Why are these ligaments important? Because in the presence of pubic joint instability from trauma, if those ligaments are ruptured, then there is distinct, definitive sacroiliac joint instability, and those folks need a fusion in the pubic joint and also in the sacroiliac joint on that side. This is standard orthopedic medicine, orthopedic surgery. There are multiple case studies and research studies in the orthopedic literature. There are different scales for grading true instability that's objectively measured with x-rays and CAT scans and MRIs. And one of those is the TILE, T-I-L-E scale. And the other orthopedic scale in the orthopedic surgery literature is the Young-Burgess, B-U-R-G-E-S-S scale. And they'll show you many different types of pubic instability, sacroiliac instability, with and without fractures in different parts of the pelvic bones. A very important position for screening the pelvic mobility and integrity is full flexion, which is child pose. I'm going to come to that shortly, and I'm going to contrast it with a position of extension. Would you come up on your elbows, please? So Holly is now in full passive lumbar extension. The sacroiliac joints like this position, they are maximally stable when someone is in extension. And of course, were she standing, she would have upper body weight compressing through that joint. It is extremely rare to find someone in this position who has instability. So if I were to do the various spring tests with her in this position and I were to perceive laxity, that would be an absolute red flag indicating that she probably has true instability. Extremely rare for someone to have that, but it does happen. Now, the position in which the SI joints are maximally open and vulnerable is when someone is in full flexion. Sitting is an example of mid-range flexion, so it's important to screen them in sitting. But in order to get them at absolute end range, to get the best picture of how the SI joint functions in full flexion, would be to take them into child pose, also called Muslim prayer position. So would you get up in child pose, please? And you'll notice that she's completely flexed. The whole spine from neck all the way down is flexed. Arms can be forward, they can be off to the side, doesn't really matter. You will notice full flexion in the hips. You want to make sure they're comfortable, that you're comfortable if you're being tested. If you have some hip pathology, it's uncomfortable, then you modify it. You might come up a little bit. But she's very healthy, no hip pathologies and no significant spinal pathologies, so she tolerates this position well. So Holly is now in child pose position, and so I come and I palpate the posterior pelvis and compare symmetry, but symmetry only means a tiny little bit. You have to find out why something looks asymmetrical, and in this position I'm going to demonstrate 4 spring tests on each quadrant of the sacrum. And I can also test forward bending of the sacrum, springing at the top and springing at the bottom. I can test almost a pure PA glide force through the pelvis. Of course, it's altered by the shape of the joint, but by doing it in a pure position, there's good reproducibility. So here's an anterior ilium rotation spring test. You can come in the front of the pelvis and induce a posterior rotation force, and yes, multiple structures move with this. So in the clinic, no one can absolutely isolate inside only the SI joint. It's coupled with other structures, and we have to accept clinical reality. It is what it is, but you can discern when mobility is excessive through this system. You can do further testing to try to separate lumbar and hip out from the pelvis and SI, and the reverse thereof. But it is important to do these stress tests to find out the name of the pattern that the person presents with very specifically. And just looking at a pelvis and saying it's asymmetrical does not mean there's any kind of instability. And I know there's a lot of marketing going on to promote that archaic concept, and it simply is not true. So it's very important to screen the SIJ with someone in child pose position, because this is where the pelvis and SIJ and lumbar spine and hip coupled as a functional unit are all in maximal flexion, the position in which, if there's instability, they are maximally unstable typically, and it's also the position in which most people injure their spines and pelvis and SIJ. So let me take a brief glance at my paperwork and see if I'm missing anything. We're going to stop filming right now, and we're going to film a separate film demonstrating important ways of screening the hip. Thank you very much.